with these beautiful colleagues in Latin America, and it's a great honor having this opportunity to give you some insight, some glimpses into ependymoma in childhood. As you all know very well, this is the third most common brain tumor in childhood, and it can develop anywhere in the neuroepithelial lining, within the ventricles or down to the spinal canal, as well as in rest cells in the parenchyma. There are about 6 to 12% of all brain tumors in children, and the majority, nearly half of them, will be diagnosed younger than 5 years of age. Ependymoma are not associated with any known syndromes, albeit there is a bit of a higher susceptibility in patients with neurofibromatosis too. However, the overall 10-year survival is inferior to children diagnosed with medulloblastoma. And this is really our task, to advance the treatment for these children. This is an example showing the overall survival of 4 different European trials, and independent of combination chemotherapy first or radiation. You see that when time goes by at the 10-year overall survival time, there is an average of 50% of children surviving ependymoma. When we look at the WHO classification of ependymoma over those last years until the most recent edition in 2016, nothing has really changed in regards to subependymoma and myxopapillary ependymoma assigned to WHO grade 1. Those are not, however, the most common tumors in childhood. Those really, the most common ones are classic and anaplastic ependymoma. And the most recent edition did not assign them any more strictly as in the past to WHO grade 2 or WHO grade 3, but indeed assigned it to both of those histological presentations, classic or anaplastic. And indeed, the WHO classification states that the practice of histologically grading ependymoma may soon become obsolete altogether. Why? Histology certainly has had hallmarks and still has. You see here to your very left typical pseudo-rosettes, and in the middle the classical true rosettes that are present in ependymoma and more commonly seen in grade 2 ependymoma. However, as the tumor dedifferentiates, it is more difficult, and you see this as an example to the very right on this slide, to distinct those 2 assigned grade 2 or 3. Distinction and aspects of vascular proliferation, for example, mitosis or necrosis, are more difficult or even truly impossible to discern. And interestingly, some of the most renowned pathologists came together and finally published now 10 years ago this work on histopathological grading of pediatric ependymoma, reproducibility, and clinical relevance in European trial cohorts. And despite their knowledge and huge expertise, they eventually really stated that no one's pathologist's approach prevailed as a correlate for outcome for children with ependymoma. So indeed, there is no association between grade 2 and 3 and survival. And when looking over the last decades, published ratios of grade 2 to grade 3 varied widely between 1 to 7 or even 17 to 1, making this distinction obviously useless. So is it time to change from the invention of the microscope that helped to describe those to more advanced techniques? And indeed, the time seems right. This was a publication by Tytler and colleagues about molecular classification of ependymal tumors across all CNS compartments, histopathological grades, and age groups. And you see, they defined 9 different groups, and in brief, classified 500 ependymal tumors using DNA methylation profiling. And these molecular classification outperformed the histopathological grading in risk stratification of patients. And that translated into pathologists' most recent update that was published just last year, that indeed ependymoma should, going forward, separated by anatomical site, supratentorial to infratentorial, prompted by those methylome profiling data. And the subsequent talk will really focus on those new divisions, dividing supratentorial ependymoma, relay positive or YAP fusion positive versus post-fossa ependymoma, post-fossa ependymoma group A versus post-fossa ependymoma group B. However, going into the future, let's just take a little glimpse back to the past. What has been the role of extent of resection and radiation? And here you see really publications dating back over the last 3 decades. And I would like to draw your attention to the near gross total resection on this column. If you see those numbers between 60 to 80% and compare them to the right-sided column for the 5-year overall survival for incomplete resection, you see that over those last 30 years, nothing really changed in regard of a gross total resection will make a huge difference and will be prognostic for chances of overall survival. These are examples of supratentorial and infratentorial ependymoma. And no doubt, these large tumors are quite difficult to resect. However, a supratentorial located tumor is much easier to resect in general compared to an inferior tumor, as those are usually encompassing all the distal cranial nerves, and a gross total resection is much more challenging in this area. A children's oncology group study called COG 0121 summarizes the role of resection as well as radiation for pediatric ependymoma, published 2 years ago, for chemotherapy for incompletely resected ependymoma, and observation for completely resected supratentorial ependymoma. And you see here to your very left those overall survival probabilities, and albeit the green line is 100% overall survival, please have a look that this relates to only 11 gross total resected supratentorial tumors, and albeit there were progressions, all of those were rescuable. The remainder, ranging from subtotal resection and chemotherapy, the green line, to a near total resection, which is the blue line, and the gross total resection, that is the gray line here, that the gross total resection refers to a better outcome compared to near total resection and subtotal resection. To your right, you see the probability of event-free survival for patients treated with immediate postoperative radiation according to 1Q gain status. And you see that 1Q status sadly refers to a worse prognosis compared to those that do not show 1Q gain. This is the event-free survival of those patients within the study who were undergoing surgery for a second time. And again, it delineates the importance of resection, as it shows if a tumor is not amenable to a gross total resection to begin with, a second surgery with reducing or ideally resulting in a gross total resection will make a difference in the overall survival of those patients, and quite significantly so. This is our own SickKids data published by Sabataki 2 years ago, and it, in a smaller cohort, however, exemplifies exactly the same. Those patients in blue who have subtotal resection and no upfront radiation do worse, while those with gross total resection and upfront radiation do best. To your right, you see the overall survival, and it pretty much transfers from progression-free survival to overall survival chances. So, in summary, gross total resection as well as early radiation are important and prognostic. What about the role of chemotherapy? There have been 2 COG trials trying to answer exactly that question, and the one I just presented, or 1-1, has been published, but still misses some final answers to those questions. The subsequent study of COG 0831 is still undergoing analysis and will hopefully be able to answer some of those pending questions. Does a short interval of chemotherapy help a second resection, and does it make the tumor more amenable to this resection and improve the rate of complete resection at the time of a second procedure? Can we reduce, with doing so, the second resection? Can we prevent with chemotherapy dissemination and distant relapses? And does maintenance chemotherapy implemented in COG trial 0831 make a difference in overall survival outcome? There are some preliminary reports on 0831 hinting in a direction that maintenance chemotherapy for a subset of patients may matter, but the final analysis should be awaited prior to jumping to too early conclusions. What we learned is, and what I already showed earlier, that ependymoma is not a single disease as histopathology suggested over those last decades, but we are dealing with different diseases according to different compartments. Already mentioned, ependymoma group A and ependymoma group B in the post fossa, and we distinguish supratentorial ependymoma, Rayleigh positive and YAP1 positive. To add to post fossa syndrome, that those of group A occur predominantly in infants and young children. They are usually lateral in their localization, and this makes them even more difficult to completely resect, hence are associated with a high recurrence rate. Post-fossa ependymoma group B tumors occur largely in adolescents and young adults and are associated with a more favorable prognosis. However, it seems not to be a group that occurs often in children of young age. This is a publication showing the therapeutic impact of cytoreductive surgery and irradiation of post-fossa ependymoma in the molecular era, and it was a retrospective multi-cohort analysis. And you see here the distinct difference between post-fossa group A ependymoma and post-fossa group B tumors, with group B doing extremely well. However, the more common group A don't do so well. Gross total resection remains prognostic significant, as does upfront radiation therapy. And this is exemplified in this paper and demonstrated here to your very left. Those are different cohorts, Jean, St. Jude, CERN, and Burdenko. And the left line exemplifies patients with subtotal resection, whereas the blue line stands for patients who underwent gross total resection. And you see the blue line is always superior, meaning gross total resection is an important achievement in these children with ependymoma. So does upfront radiation therapy. You see the Kaplan-Meier curve with identifying upfront radiation therapy and the blue line being superior. More recently, more genetic aberrations have been identified in addition to the 1Q gain. That is again in this paper exemplified. Those patients with post-fossa tumor and 1Q gain do worse, and they do extremely worse when a 6Q loss is in addition. This is shown here in the red line, 1Q gain and 6Q loss. Post-fossa ependymoma patients are the worst, have the worst prognosis. Another trial, but documenting exactly the same, showing 1Q gain in the red line here and balance of 1Q with significant difference in outcome. Different entities are supratentorial ependymoma, and here we distinguish supratentorial ependymoma from type RELA and YAP1. You see the majority of children with RELA supratentorial ependymomas, those are characterized by fusions between C11 of 95 and the RELA gene, and the remaining molecular subgroup of supratentorial ependymoma harbors recurrent fusions of the oncogene YAP1. Why do we see such different outcomes in our anaplastic and classic ependymoma when we did it in our previous based manner on histology? This is unpublished data from Vijay Ramaswamy, who looked at supratentorial ependymoma 144. And when running those tissues through methylation array, there are 25% of those supratentorial ependymoma that are not ependymoma molecularly, and that's consistent across all centers. There is a mix of glioblastoma, some pleomorphic xanthoastrocytoma, even some oligodendroglioma. And it's important to realize that obviously when a group of non-ependymomas are within the histological classification, then we will not advance the field with improving and directing outcome in the proper way. So it's not always easy to distinguish one way from the other, and sometimes ways may be aligned, but in regards to advancing the field in CNS tumors, this way of really adjuvant and important insight on a molecular level is absolutely important and essential. And coming to the end, I would like to just summarize some of those highlights that are as well highlighted in the general consensus statements published by colleagues a couple of years ago, that outside of clinical trials, treatment decisions should not anymore be based on just grading 2 versus 3. It should be noted that supratentorial ependymoma and post-fossa ependymoma are different diseases, although the impact on therapy is still evolving. Central radiological and histological review should be a principal component of future clinical trials. Subgrouping should be part of all clinical henceforth. Fresh frozen tumor samples should, as well as blood samples, be mandatory for future clinical trials in order to advance this field. This is a suggestion of advances in the molecular classification of pediatric brain tumors published last year by Cacchiotti and Ramaswamy, and it distinguishes supratentorial from post-fossa ependymoma with really clear distinctions of YAP, RELA fusions, as well group A and ependymoma type B, looking at resection as well as suggestions of how to approach those children in future investigations. Those colleagues had an additional title to their advances in the molecular classification of pediatric brain tumors, and they named it A Guide to the Galaxy. I'm not sure if Chantal Cacchiotti and Vijay Ramaswamy had such an image in mind. However, it does seem that our new and growing understanding into molecular characteristics of pediatric brain tumors opened a truly huge perspective that hopefully can one day translate into clinical practice and improve the outcome of our children affected by ependymoma. Thanks so very much for listening and your attention.